Good afternoon, everyone. Thank you so much for attending our fifth shadowing session. Today, it's our pleasure to have Dr. Bosley, a dermatologist, as our guest physician. Please remember that the Google form will be posted in the comments at the end. With that being said, Dr. Bosley, you may start sharing your screen whenever you'd like.
All right. Thank you guys for having me. I hope everything looks good on your end. As mentioned, I'm Dr. Ron Bosley. I'm a dermatologist in the Dallas-Fort Worth area at Prism Dermatology is the name of my practice. Again, thank you for having me, and I'm happy to kind of give you guys an opportunity to see kind of what a day of dermatology looks like for me. I am just a little background on me. So I went to Howard University for undergraduate, majoring in biology, kind of pre-med track. I'm originally from Ohio and went to the University of Cincinnati College of Medicine for medical school, followed by Wayne State School of Medicine and the Detroit Medical Center for my dermatology residency. My training in dermatology was pretty broad, which is one of the great things about the specialty is you can have a pretty wide range of exposure. I like to always say dermatologists get the opportunity to be internists, pediatricians, surgeons, pathologists, kind of whatever track you decide to do. You can pretty much focus on those things as you kind of progress through your training. So, my particular interests in dermatology are procedural. And so you'll see today a kind of a mix of what we call medical or general dermatology with a mix of some of the procedures that we do. So let me pull this up. All right, here we go. Backing up a little bit. There we go. All right, case number one. So I'm going to pull up the YouTube page here. Case number one, we'll start with this patient here. So this is a 37-year-old male who comes into the office with this 4-month progressive history of just, as you can see, hair loss. We're looking at the gentleman's scalp. In dermatology, we like to use a lot of fancy descriptions. So the way I would describe this case is diffuse coalescing, so patches that come together of hair loss involving the scalp, and what you cannot see is the gentleman's eyebrows. So, there are a couple of things that come to mind when I see this type of patient. One of the things that we have to first do is take a good history. So dermatology, although it is a very visible specialty, oftentimes within seconds, we can come to a diagnosis for a particular case. It's still important to kind of go through the steps of getting history, of getting more information from the patient so that you can help narrow your differential diagnosis into one. So what things will be helpful? Just like other cases, you want to understand if someone has with their medical history, what therapies they're taking, or medications they're taking, how long this is happening, what's happening in their social life. And so we generally, especially for our new patients, get a past medical history, medication list, surgical history, social history, which for dermatology, interesting enough, is a very important aspect because a lot of things that we do socially, whether it be profession or things we do at home or things we use at home, can affect our skin. And so I'll look for any comments or questions as we go along. So please feel free to comment. I'll try to pause and just ask questions. But of the options here, does anyone have any thing they would like to ask the patient as far as the A, B, or C? The answer could be one, or they could be all of them. I see a couple B's, which is a good one. So my general approach is 4 months. So tell me, how long does this happen? 4 months. Well, did it happen all at once, or has it been progressive? As we mentioned, it was a progressive hair loss. over a 4-month period, but 4 months is a pretty short amount of time for hair loss. I see a lot of bees coming in. So to answer your question, yes, B is a very important thing. Um, Thyroid and hair loss is very well connected. There are several types of hair loss that can be caused by changes in the thyroid here, whether low thyroid or high thyroid. I see some other suggestions for all, which is another good one, and another suggestion for stressors in life. And all of these are important, and I'll explain why. So when you see a very progressive type of hair loss, it can be something that is caused internally, like thyroid disease, but it also can be caused by external factors like stress. There is a form of hair loss called telogen effluvium, where all of our hair that are in the telogen phase, that's the resting phase of hair, falls out pretty quickly. Now, luckily, in general, most of our hair is not in telogen phase. So when people have this telogen effluvium, they generally lose 20, maybe 40% of their hair, but not 100% of their hair. However, there are other conditions, usually in the pediatrics, where people can have anagen effluvium, where they lose all their hair. That's kind of what happens when people undergo certain types of chemotherapies. They lose all their hair due to this anagen effluvium. So, our patient, generally healthy, not on any medical therapies for cancer or chemo. So, anagen effluvium may not fit in this situation. But we're in the midst of a pandemic, so recent job loss can cause stress, which can trigger this telogen effluvium. So that's a really appropriate question. And a couple people put A, which is not a wrong answer. I think my answer will be all of the above. And the reason being because there's another type of hair loss that can cause this patchy hair loss, and that's called trichotillomania. And that's often associated with underlying psychiatric disorders such as obsessive compulsive disorder. This is a condition where people chronically may pull or pull their hair, essentially causing it to fall out. Now, this gentleman probably would have had to do quite a bit of pulling out of the hair in order to pull this much hair out, but it's always a good question as you get a thorough history. Another important thing about dermatology is our physical exam. So, as I mentioned, gentleman walks in, hair loss, obviously our attraction to our eyes will be to seeing their presenting problem, which is on the scalp and the face. But it's very important to look elsewhere. Oftentimes we can get clues of narrowing our diagnosis by searching for other clues on the skin and also in the history, as we talked about. Anybody have any suggestions where else we can look, whether it be the hands, the rest of the face, the body, or inside the mouth? Okay, I see a couple things coming in so far. Hands and face, that's a really good start. Face, mouth, okay. So a nice range, of answers, mostly starting with A and B as the top answers so far, and I think those are both fair. Um, Going back to some of the diagnoses that we talked about, looking at thyroid disease and telogen effluvium, the hair on the scalp would be um, the most prevalent, seeing that telogen effluvium. However, looking at other hair bearing areas would be important. So the trunk would also be a suggestion, especially for men who may have hairs on the arms and the trunk, although telogen effluvium commonly wouldn't affect those areas. It's just good to do a thorough check. Yeah, someone mentioned hair loss in other areas, so that's absolutely correct. Um, Anyone have any thoughts on what an examination of the hands might show, or what area of the hand would I be most likely to look at or to care about? I'll pause for a second to see if anyone has any suggestions. Okay. So the hands are very important in dermatology, A, because we usually can see these on any given person, any given exam. And there are aspects of the skin on the hands that are important, but also the nails. So nails are really telling in dermatology. There are a lot of things that can show up on the nails that may help narrow a diagnosis, whether it's a hair loss diagnosis, a rash diagnosis, or other. And looking at this gentleman's nails, we see somewhat uniform pitting of the nail plate. And this is actually a associated diagnosis with what this gentleman actually has. Any other tests needed? So we talked about our history, pretty healthy gentleman, maybe stress at the job, um, stress with recent pandemic, 4-month history of progressive hair loss. Do we need any other tests before we make a diagnosis? Let's see what we have here. Some people are talking about doing blood tests for minerals and iron tests. Those are all great suggestions. Okay, thyroid studies, good suggestion. Vitamin deficiency, all great. So yes, so thyroid, vitamin deficiencies, vitamin D, vitamin B12, zinc, magnesium, those are all lab values that could be important if you're looking for a diagnosis. Anybody think we need to do a skin biopsy? Okay, a couple, okay. Yeah, a couple thoughts on skin biopsy. So skin biopsies are very helpful, especially for hair loss, because oftentimes we can look under the microscope and see a pattern of hair loss. A lot of hair loss is related to inflammation, and the different patterns of inflammation can help you determine what the diagnosis is. For this particular patient who presents with no underlying symptoms, no symptoms of thyroid abnormalities, no heat cold intolerance, no changes to his appetite, no changes with bowel regularity, constipation, diarrhea. Those are all things that I want to ask this patient. And if he says he has no symptoms, the current guidelines suggest that we do not have to do thyroid studies at this time. Additionally, with him presenting to me with 4 months of progressive hair loss involving the scalp and the eyebrows, with the setting of the pitting on the nails, I think I'm comfortable making a diagnosis without needing extra tests. However, I generally will recommend to patients there may be some additional tests needed if we're not making progress with the diagnosis. So anybody want to take a stab at a shot at the actual diagnosis that we have so far based on the pitting of the nails and the loss of hair over the scalp? Okay, I see a couple of things thrown out there. So what I'll do with this is give you guys a diagnosis, and then we'll kind of talk about why it's not other things. Fair enough? So this is actually alopecia areata, kind of progressing to something called alopecia totalis. So what is alopecia? Alopecia is actually the medical term for hair loss. So a lot of people use this term not necessarily incorrectly, but they kind of put alopecia as a broader diagnosis, whereas there are specific types of hair loss. And this specific type of hair loss is alopecia areata, which typically shows up as very discrete, 1 or 2 oval patches on the scalp most commonly, but it can actually show up on other areas of the body as well. So our examination of the trunk and other hair-bearing areas would have been valuable. Alopecia areata is a autoimmune condition, meaning it is caused by your own body attacking the hair, therefore causing the hair to fall out, usually in discrete oval patches. However, these patches can coalesce to involve larger areas or involve the entire scalp and even brows, and that's where it's alopecia totalis or total brow and scalp. There is another broader form of alopecia areata called alopecia universalis. That's where we lose hair everywhere. So doing an examination head to toe, or at least on the hair bearing areas, would have helped you with this diagnosis. So a couple people talked about trichotillomania, which is the hair pulling disorder that we talked about. And that's very valid. I think that if the patient did not have the nail pitting that we saw, if the patient was displaying some signs and symptoms of obsessive compulsive disorder or some other depressive symptoms or some other anxiety or reports of this, trichotillomania would have been a little higher on my differential. If we have a kind of equivocal history, we're not quite sure what's going on, then that's where those other tests would have been helpful, especially a biopsy. So biopsy of alopecia areata typically shows inflammation around the bottom of the hair follicle, which is indicative of the autoimmune inflammation that's causing the hair loss. And a skin biopsy at that point would have been beneficial to help differentiate the two. Let's see what else. Yeah, so what do we do next? So alopecia areata is typically treated with anti-inflammatory since it's an inflammatory condition, whether it be topical anti-inflammatories, injections of steroids into the areas of hair loss, or oral medications that can be given. As I mentioned before, thyroid is very important in multiple types of hair loss. Alopecia areata used to have we should think it had a very tight link to thyroid disease. However, we now realize that it may precede thyroid disease. So patients who don't exhibit signs and symptoms of thyroid disease, we typically don't routinely run tests, although I generally recommend that they see their PCP for a primary care physician for evaluation, especially if they're having symptoms of thyroid abnormalities. And then lastly, vitamin deficiency. So this patient did not report any signs and symptoms of vitamin deficiency, so that is not something I will routinely run. However, if there are any signs and symptoms of vitamin deficiencies, that will be a part of my workup with alopecia areata. Anybody have any pressing questions? So someone asked about would a steroid eventually thin the skin over time from use? The answer to that question is yes. Steroids as a side effect can thin the skin. However, if properly used, steroids applied topically to the skin or via injection, we can reduce the risk of thinning the skin with proper use. Typically, what I call steroid vacations, where you're using a steroid for a certain amount of time, stopping for a little while, and then repeating therapy as needed. Those are helpful. And then picking the right steroids. So topical steroids generally come in 7 classes. When we think of class 7, that's kind of your hydrocortisone cream over the counter, whereas class 1, such as halobetazole, clobetasol, those are topical therapies that are usually reserved for really severe rashes or really inflammatory rashes. And those are more likely to cause thinning than your weaker class of steroids. Generally, patients do recover completely from alopecia areata, although the more involvement, if it's involving 50% or more of the hair, typically the longer the course, and unfortunately, the longer the treatment as well. And also, it can recur. So some people may have alopecia areata as a child, and then 20 years later, develop another patch. And that is why we continue to monitor for associated symptoms like thyroid. All right. So lots of great questions, but I'm going to move on to case number 2 so that we can get through this in a timely fashion. So this is case number 2. So this is a 43-year-old female who presents with these intensely itchy, hyperpigmented, slightly raised plaques on the lower extremities. So any thoughts on what questions we should ask? Any other suggestions on where we should look in this patient? And from there, what kind of disease process would this be? So a couple of people are asking questions about steroids, and I'll kind of touch on it in this case as well. But generally, topical steroids are used across a wide variety of dermatologic conditions because a lot of conditions are inflammatory. Um, Topical use of steroids, there's very minimal systemic absorption, so it doesn't get in your blood. And therefore, some of the side effects that people think about steroids don't happen as frequently with the topical use. So in this case, we want to think about sun exposure, allergies, whether it's to medications or food, associated pain. Those are all good questions. This patient particularly says, I'm just itchy. I mean, I'm itchy all over my legs. This has been happening for several weeks and it's getting worse. I can't control the itching. I've tried Benadryl at home. I've tried aloe vera to soothe, but nothing controls the itching. And so when I look at these itchy plaques on the lower legs, there are a couple of diseases that come to mind. So after asking appropriate questions, I develop a differential diagnosis. And thus far, my differential diagnosis is atopic dermatitis. So that's what eczema is. When most people refer to the word eczema, they're generally referring to the chronic condition of atopic dermatitis. The second option B is a condition called prurigo nodularis. Prurigo derives from the word pruritus or itch, and nodularis, nodule. So itchy bumps is kind of where they get that term from loosely. Lichen planus is another condition that is very itchy, usually shows up as small bumps on the body. And lastly, this acquired porphyrating dermatosis. So what the heck is that? That is a condition that can show up as itchy bumps on the extremities, and it's usually related to underlying kidney or liver disease. So a couple more questions for the patient. Do you have any allergies? No allergies, no history of diabetes. When she touches it, it's very itchy, but no pain, no other associated symptoms. She uses pretty good stuff. She's never had a history of itching like this before. She uses sensitive skin products just because she's always used Dove and petroleum jelly as her moisturizer. She doesn't have any pets. All these are really good questions to help narrow your differential diagnosis. So based on that information, I can start to somewhat eliminate some of these differentials, but we still have to do our physical exam. So where else should we look? I just gave you a hint, but we'll see if anybody else has any other suggestions. The rashes doesn't have any exacerbating factors. That's also a good question. You know, what makes it better? What makes it worse? That's always a good question to ask for any rash because it can help you narrow your diagnosis. The rash is spreading and therefore getting bigger. But where else should we look? Feel free to say everywhere because that's oftentimes where we have to look. Yeah, I see my hint really helped out a lot. But the answer to this question is actually everywhere. So although the patient comes in with a very itchy rash on the lower legs, I like to think of the body as being very symmetrical, right? So if someone comes in with a rash on their forearm, people have two forearms. So make sure you look at the other side, but think about what's similar on the body to your forearms, and that would be the lower leg. So if someone comes in with a rash on the lower legs, I always look at their arms. If someone comes in with a rash on the left leg, I always look at the right leg. If someone comes in with rashes on their fingers, I always look at their toes. So you always want to kind of look at, you know, there's similar parts in your upper body that there are to your lower body. So making sure you examine those things can help give you a hint. But yes, the mouth is a very important place to look, in addition to the nails, in addition to the scalp. So in the mouth, we see this lacy white reticular rash involving the buccal cheek. And this is actually very helpful in establishing a diagnosis and in eliminating some of the other options. So what test should we do? Full body exam, I love it. That's a good answer. So any other tests or suggestions of what we should do? We now have two findings, both on the skin and the mouth, and a good history. Do we need to do any additional tests to figure out what's going on? And once again, I think with two very strong findings, I think we can come to a preliminary diagnosis while ruling out some of the others. So in this patient, one of the thoughts I had was atopic dermatitis. Atopic dermatitis generally is something that shows up as a child, although people can develop eczemas as they get older based on exposures or whether at home or environmental exposures. Given the fact that this patient said she didn't have this rash growing up, this is the first time she ever had it. Atopic dermatitis, it lowers on my differential, although it's something to consider. Similarly, prurigo nodularis, this is a rash, as I mentioned, prurigo itchy nodularis or nodule or bump can show up as itchy bumps, but typically this is a chronic rash. This is usually caused by people scratching at something for a very, very long time, usually weeks, but most commonly months or beyond. And the fact that she hasn't had this rash very long speaks against the development of prurigo nodularis. This is something that happened pretty abruptly, whereas prurigo nodularis would take time to develop. Would a biopsy help me with all this? Absolutely. However, I tend to try to use what's between here to help get a diagnosis. And if we need to do a biopsy, although biopsies are low risk, it is involving cutting into the skin, and there's risk of infection and scar. So I try to avoid those things if I can come to a diagnosis with using the clues that the patient has given me through their history and through their physical exam. So at this point, I'm going to skip additional testing. And I just skip past this. Let's skip additional testing and talk about the diagnosis. I think that slide got deleted, but let me go back and explain it. So this is actually lichen planus, which was on our differential. This was our third or letter C here. So lichen planus is this inflammatory condition that can run in families sometimes. It is thought to be genetic. There's a genetic predisposition for, however, it's not something that's passed down. I usually see it in families, like I had an example today, where grandma may have had these itchy bumps on her wrists, whereas the granddaughter all of a sudden has this rash head to toe. And it commonly presents as that, where people have a family history of some rash that was not diagnosed. There is a variant of lichen planus called hypertrophic lichen planus, where we get these thick plaques, usually on the lower extremities. And this is pretty consistent with that diagnosis. So this case is one in which we could have made the diagnosis immediately walking into the room with a little bit of history. But as I mentioned, it is very important to get your history to make sure we're ruling out other causes. The other options that I talked about as far as blood tests and things, lichen planus wouldn't necessarily show any lab abnormalities, so you wouldn't necessarily need to do any blood testing. However, a skin biopsy is pretty helpful in diagnosis, especially if A, they failed treatment, which we'll talk about here in a moment, or B, if you're unsure of the diagnosis. So lichen planus usually has this classic description under the microscope called interface or lichenoid dermatitis. So when we remove a piece of skin and we look under the microscope, right underneath the skin, there's this thick band of inflammation that goes across, and that's pretty consistent with lichen planus or lichenoid dermatitis. So skin biopsy is a great plan B if you're struggling with coming to a true diagnosis. The treatment for this, as I mentioned, with that thick band of inflammation under the microscope, is treating with anti-inflammatories such as topical steroids. So those are generally first line and are used our stronger, ultra potent topical steroids are used 2 or 3 times a day for 2 or 3 weeks to kind of get this clear up. We can also treat it with oral steroids and other oral anti-inflammatories, especially if the patient has a disease that's not responding to topical steroids, or patients have generalized disease where it's just difficult to put creams everywhere. All right. So let's get over into some fun stuff. So switching gears a little bit, now into case 3. The previous diagnosis was lichen planus or hypertrophic lichen planus. So case 3. So we have this gentleman, 39-year-old male. He comes in with just a lifetime history of excessive sweating. He's in your office. You can look at his underarms and you see just sweating. You know, it's not too hot out. You're in an air-conditioned office. You would assume most people wouldn't be profusely sweating like this. So he says, "Doc, I've used every single deodorant on this earth, and I just want to fix this. What can you do for me?" So a couple people are throwing out some really good diagnosis, which is hyperhidrosis. So this is exactly what's going on. There are several types of hyperhidrosis. There's a generalized hyperhidrosis, so people who sweat kind of everywhere. There is focal hyperhidrosis, so focal meaning one area, so the hands or the axilla or genital areas. I see a couple good suggestions for treatment going out there as well. So this is primary focal axillary hyperhidrosis. So what questions should we ask the gentleman before we get into his treatment? Hey, I see you sweating on your arms. Do you sweat other places? Is it triggered by stress? Is it triggered by uncomfortable environments? Is it just in the heat? Do you sweat also in the cold? Are you on any medications? Those are also a part of our history. But assuming we've done all that, we'll kind of go into his options. So aluminum chloride. This is a first-line treatment for primary focal axillary hyperhidrosis. Aluminum is also in a lot of antiperspirants and deodorants. So I say to the gentleman, hey, we can try this prescription strength topical that you apply at night to clog your sweat glands and signal your body to stop producing sweat. And he says, I don't want to do it. I've tried everything. I'm beyond that. So what else do we have? You have glycopyrrolate. So this is a prescription oral medication that is helpful in kind of shutting down the signaling, the chemical signal that tells your sweat glands to create sweat. This is a pill that you take 1 or up to 4 times a day, or 4 pills a day, to help with the sweating. We offer this gentleman this option. He says, I don't really want to take pills. I'm not into pills. I'll forget. What else do you got for me, doc? And I mentioned these diagnoses as options, at least, the treatments for primary focal axillary hyperhidrosis, but the first 2 options are also helpful for other areas like focal hydrosis of the hands, and glycopyrrolate is both helpful for focal hydrosis and for generalized hydrosis. So then we bring up this big word to him, and he says, what is that? Well, when we talk about sympathectomies, we're talking about a surgical procedure to diminish the signaling to your sweat glands to produce sweat. So as soon as you say the word surgery, this guy's like, no, I'm not doing surgery. You have to have something else for me. And I think someone actually mentioned this before, and they did. And that is, well, before that one more option. I said, well, there is this treatment using electromagnetic energy where we can literally just kind of fry the sweat glands. There's a treatment called mirror dry, which is very beneficial for focal axillary hyperhidrosis because it permanently reduces sweating up to 80–85% for most. He seems pretty interested in it until I say, well, unfortunately, this is a treatment not covered by your insurance. And so it has a pretty high out-of-pocket cost. So He said, you know what, doc, I'll think about that, but you have to have something else for me. What can we do? And someone actually mentioned it before, and that's botulinum toxin or Botox. So he says, let's do it. Obviously not the same patient, but botulinum toxin is something that we use to treat, especially in the axilla, focal axillary hyperhidrosis. Similar to the other medications, the premise or the goal behind this treatment is to slow down or to disrupt the signaling between the glands that's cause secretions of sweat. And the reason why this patient is willing to do that is because it's longevity. Unlike having to take pills every day or having to apply solutions or deodorants or antiperspirants to your skin, which may also cause other issues like skin irritation, botulinum toxin therapy for hyperhidrosis can last several months. On average, 3 months, but I've had some patients who have a significant and noticeable decrease in sweating for up to 6 months after treatment. This is oftentimes it can be covered by insurance, although usually patients have to try and fill other treatments. Another thing that's not shown here is we typically can do a starch iodine test. So what that test does is it actually shows us where in the armpit or the axilla that the majority of the sweating is happening, and we can target our therapy, our botulinum toxin therapy, directly into those areas so that we can reduce the sweating. This gives your patient the opportunity to not have to put on 15 layers, ton of layers of deodorant or antiperspirants, not have to reapply throughout the day, and can generally live what we call a normal lifestyle with applying their antiperspirant daily while enjoying 3 months without excessive sweating. So a couple questions here that I'll address. Do you get what we call compensatory sweating? And the answer is no. So generally, when we disrupt the signals from the sweat glands, you still sweat. So it's not 100%. However, it is normal to have a little bit of sweat. Patients usually come see me because the sweating is too much. It's causing some type of physical, even emotional distress. So by doing these treatments, we're actually reducing you to more of a normal or slightly less than normal amount of sweating. And so you still sweat, so your body doesn't necessarily have to compensate by causing sweating elsewhere. This treatment for someone who, imagine if you were dealing with a situation where you had to put medication on every night, followed by your deodorant every morning. It gets quite cumbersome. And then most of these people, they sweat at work, they sweat at school, they sweat throughout the day. So they're reapplying these treatments throughout the day. So the benefit of this Botox therapy is, although it only lasts 3 months, 3 months is a very long time when you consider the twice a day, 3 times a day application that some of these patients are having to do just to maintain a normal social life and not sweat through their shirts throughout time. So if someone is looking for a longer term therapy that's not going to cause systemic side effects or not requiring taking pills every day, Botox is kind of a happy medium for patients. And Botox can also be used on other areas. So we presented the underarms, however, it can be used on the hands and other areas, even the scalp. For some patients who have excessive sweating in the scalp, we can do a microdose botulinum toxin for that treatment. All right, so great questions coming through, but in the interest of time, I am going to skip to the next case. This is a fun case. It's a little curveball, as I like to call it, but let's walk through it. So this gentleman comes in, he says, Doc, I'm 56 years old and I just can't get rid of this belly fat. I don't care what you need to do. You can freeze it, you can burn it, you can suck it out. I just need your help. Can you help me? So any thoughts on this patient who presents with, just increased fat kind of apparently in the tummy area, which is a very common problem for a lot of people. And luckily, body contouring is a part of dermatology that is expanding, and there are options, both surgical and non-surgical, for these types of patients. But any thoughts? Oh, another good question. Someone says, is this the Botox in the previous case the same that's used in for cosmetics? And the answer is yes. So it is botulinum toxin A, which is the same strand of botulinum toxin used in Botox and Dysport for aesthetic concerns. So to answer that question. So a couple people throwing out some options. Exercise, that's a really good one. Cool sculpting, that's also a good one. That is cool sculpting, for those who aren't familiar, is a non-invasive body contouring treatment where you can literally freeze fat away. Liposuction, tummy tuck, all good suggestions. Lifestyle, exercise, that is really good. Some people may not understand how to eat properly or exercise properly in order to lose certain types of fat. So as a physician, it's also helpful to guide people in that direction. So we say, sure, we can help, but are there any questions we should ask? I think I see some coming in. Check for alcohol abuse. Very good. Getting a social history and making sure that we don't have any types of substance abuse or even food abuse or food dependencies or other drug dependencies is very important. Diet change, digestive issues, yes, we always screen for those. So I guess the point I'm making here is this patient comes in for a aesthetic concern, essentially, but as medical doctors, it's our job that we're not just treating aesthetic concerns, that we're also treating any underlying medical conditions that may be causing these issues. So we always do a physical, we always take a history, we always ask questions to rule out underlying disease before we jump into cosmetic or aesthetic treatments. Does anybody notice anything else on this patient's exam? So he comes in complaining about his belly, but does anybody see anything else that might give us a clue on what's going on? I see some good things coming in. So what can cause excess fat? Well, yes, there are medical conditions, especially thyroid conditions, that can make people gain weight. There are medications that can make people gain weight. So making sure we screen for that is important. This patient does not have any thyroid disease. Family history, that's a really good one. So he did mention that his mom or his dad actually had a similar body type. He just didn't know what to do with it. He just didn't want to end up like his dad. Arms, yes, I love it. Good job. So looking at this patient's arms, his arms look pretty, he's either pretty jacked or his arms are just kind of more or skinny or smaller than you would expect for someone to have such a large abdomen. And so this is good. So doing our job, our due diligence to take history and do a physical exam, we noticed that this person has abundant adiposity or fat in the abdomen, and decreased adiposity on the extremities, the arms, the forearms, causing this muscular appearance uh, on the arms. So I kind of jumped ahead here, but we got all these histories. Family history, his father was the same. He's not on any medicines. He actually hasn't really been to a doctor in a while because he was embarrassed of his weight gain over the last few years. Cushing's disease, that's a good thought. That's a good thought. All things that we want to rule out. So in this patient, I would actually get some blood tests. I would actually want to understand what his thyroid studies look like, what his metabolic studies look like, what his blood counts. Does he have diabetes? Does he have hypercholesterol? Does he have hypertension? So I would actually do a panel of testing to see what's going on and why he may be retaining weight. Does he have adequate kidney and adrenal function to rule out Cushing's disease? And any other metabolic conditions. So this is actually lipodystrophy. So what is lipodystrophy? So lipo meaning fat, dystrophy meaning dystrophic uh, or damage. And this is actually where we have fat that is, we lose fat from certain areas or gain fat in certain areas. So there are several different types of common lipodystrophies. One of which is HIV induced. So once we have a indication that this may be a lipodystrophy, checking for infections such as HIV would be helpful, especially in this patient who mentioned that he hasn't been to his primary care in quite some time. There are some lipodystrophies that can be genetic or that show up in the pediatric population, which actually are quite a few of them. But you can have an acquired generalized lipodystrophy where we lose fat from our extremities. And this gentleman, as in your exam, noted that he had quite a bit of loss of fat in the arms. Um, Conditions to screen or monitor for. This is, as I mentioned, you want to rule out diabetes, high cholesterol, kidney failure, liver failure, also adrenal disease, as someone mentioned, because people with lipodystrophy may have these associated symptoms with them. And so, although this patient came in for a medical concern, I'm sorry, cosmetic concern, we had to do our due diligence as medical doctors to rule out underlying disease. So we do all that. He has diabetes. We get him set up with his primary care. We get his diabetes under control. But he's like, Doc, can you help me still? I mean, I still have this fat here. I wanna see. Is there anything we can do for it? And yes. So for lipodystrophy, even though we can't necessarily fix the problem because of the underlying genetic predisposition, there are some things that can be done to help reduce localized fat. Here, this is tumescent liposuction, which is done by putting numbing solutions underneath the skin into the fat with the patient awake and suctioning fat away. So this is a very beneficial treatment for what we call larger volumes of fat or areas of fat where it's not just localized pockets to remove oftentimes liters of fat solution or fat from a patient. There are some non or less invasive treatments that can be done, including cool sculpting, which someone mentioned before. Cool sculpting is where we use cool uh, suck devices to literally freeze the fat. So fat does not like cold temperatures. It also doesn't like hot temperatures. And we can cause a controlled apoptosis or cellular death of the fat cells by either cooling them or heating them. Cool sculpting is probably the most popular cooling therapy, where there are other therapies, lasers, radio frequencies, devices that can heat fat and cause similar changes. So what other options do we have for fat? So this is another patient who presents with um, just a family history, a personal history of just a double chin. So all of her life, she's reported having a little bit extra fat. You can tell by the patient's body habits that the rest of her is not necessarily, she's not fairly obese. I mean, she has no signs of obesity in the neck and the face, just this pocket of fat. So this is another therapy using kind of melting the fat with a solution called deoxycholic acid. Deoxycholic acid is actually an acid that's found in the body. It's found in our bile system to help break down our digestive fats. And so we use this in dermatology as a body contouring option to treat localized areas. So unlike the gentleman before who had a generalized area of adiposity in the abdomen, we can use these non-invasive techniques such as the deoxycholic acid, also cool sculpting, also heating to melt fat. And someone asked a really good question. How is apoptosis initiated by cool temperatures? Well, think about it. All I think about is this: you're kind of freezing a cell, and once the cell is frozen and thaws and actually massage, it actually turns on the apoptotic cascades because the intracellular contents are frozen and damaged. And so the cell ruptures, and this happens throughout the treatment area. So most of the body contouring devices and procedures generally cause a 15 to 24% reduction in the fat in the treatment area, which doesn't sound like a lot, but I mean, if you lose that amount of fat per treatment, it can really make a difference for those who have localized areas of fat, like this patient here, or for patients who have localized fat on the lower abdomen, the arms, etc. So for those who missed it, the treatment for the last case was doing a great history, doing a good exam, and treating the area of fat with liposuction. All right, so back to medical derm. All right, so a couple more cases and then we'll wrap up. This is another patient who comes in, 49-year-old male with red, brown, shiny plaques on the anterior legs. So back to our train of thought. So previous to similar previous cases, what do we want to ask the patient? You know, what are we thinking? Where do we want to look? Anybody have any suggestions? Couple good questions coming in about about the body contouring case. So cooling and heating can damage the skin. However, the skin is protected in those cases by the device. So typically we have some type of covering protecting the skin from the cold, or we have an applicator that transduces the heat beyond the skin into the fat so that we're not damaging the overlying skin. So that's a really good question. Same thing with the acid. So the acid is injected into the fat layer, not into the skin, because if injected to the skin, it can cause skin damage. And deoxycholic acid, by its nature, breaks down fat, and that's how it helps break down the fat in our digestive system from our bile system, or our gallbladder and our bile ducts. All right, a couple of thoughts. So someone put psoriasis. That's a really good suggestion. Psoriasis is a very common skin condition that shows up as red plaques on the body. Typically, psoriasis has scale, which this does not necessarily have the classic scale of psoriasis, but that's on the differential. So always build a differential when you're looking at a skin disease, at least 3 to 4 things that it could be, and that can help you narrow down the questions you ask the patient, but also other testing that you may need. Good. Is it painful or painless? So this is a painless rash. Someone's been listening. They said we should also look at the arms, which is right. So again, if someone has something on their lower leg, make sure you look at their forearm. This patient does not have any rashes elsewhere on the arms. Shingles. Good thought. So infection in general. Good thought. Lupus. That's a good thought as well, especially because of the shiny, thinning nature of it. That's a good thought. All right. So moving on. I would do an exam on this patient, looking at the upper body, the trunk, including the arms. And I would also get a history. You know, do you have any underlying medical conditions? Do you have any history or family history, things around the family? Do you have a history of psoriasis? Do you have a history of joint disease? Oftentimes, skin findings can be associated with underlying conditions or other conditions. So asking those questions are helpful. So let's work on differential. Someone nailed it earlier. Psoriasis would be very high on the differential. One question I would have for the patient is, had they treated this before? because psoriasis can often look different if it's partially treated than if someone presents with kind of full-blown psoriasis, which again would show up as red or erythematous plaques with silvery scale on the body. This patient said, I haven't treated anything. This is just shown up over the last couple years, and I haven't really touched it. And now I'm coming to see you for it. Someone made a really good, another differential diagnosis of burns. So that is a good question. A good differential. These plaques are somewhat geometric. They're kind of circular shaped, and in some areas there's a haphazard pattern. So burns or the skin healing from a burn is a really good thought. Generally, patients will report that in their history. And, I had this accident or I had this chemical burn or this electric burn. Probably not electric given the pattern, but that's a really good thought based on the differential, and he didn't report any pain. So that would also kind of eliminate acute burn. However, if it is a healing skin, the skin is healing from a burn, pain may not be a part of the presentation, but again, the history would speak to such. So granulomatous dermatitis, that's something I threw on the differential. Anytime I see a chronic rash that's been there for a while, that's somewhat indurated or in the skin, I think of this catch-all term of granulomatous or chronic dermatitis. Someone said, ask why they waited so long to go see the doctor. That is a very good thing to ask. And that will be important as we just talk about this case a little bit further. So lichen planus. So we had a case earlier of hypertrophic lichen planus. Remember, lower leg, plaques, think lichen planus. However, this patient did not report itching, which is usually a very prominent symptom in lichen planus. So we kind of asked those questions. I'll kind of skip over this part. So what test do we need? Someone says skin biopsy. Bingo. I think that's a good idea. It is the lower leg. I usually try not to do skin biopsy in the lower legs unless I have to. But in this case, I would probably do one just because it's helpful in diagnosis. It's also cool to look at under a microscope. Yeah, someone brought a good point. So a lot of times patients don't present to dermatology in a timely fashion, what we would consider timely, because they think skin conditions will go away. And oftentimes if they're not symptomatic, they're not itchy, they're not painful, they usually don't think about it until it's often brought up by spouses or family members, or if it's progressing over a long time. So as a dermatologist, it's important to know how things look both in their acute phase and their chronic phase. Oftentimes we're not seeing patients within weeks of developing a problem. It may be years down the road, and we have to know what years of untreated psoriasis, for example, looks like versus fresh psoriasis. So that's a very good point someone made. So any thoughts on testing, anyone? So skin biopsy, I definitely agree with that. Yep. Schomburg's disease. Wow, somebody been reading dermatology. So what's Schomburg's disease? Schomburg's disease or pigmented purpuric dermatosis is a condition where we see these red-brown, more macules, sometimes papules on the lower legs. And it is thought to be related or is related to lower extremity swelling, edema, ruptures of capillaries, and deposition of iron from our blood vessels or blood cells into the skin, giving it this red-brown discoloration. This patient does not report swelling. And these plaques are much larger than the classic macules or small papules that we see in Schomburg. So, but that's a really good thought. Yes, A and C. Those are good options. Check for blood sugar, diabetes. Okay. all good answers I'm seeing across the chat. I think for this patient, the most important thing that I would do, given this is a very classic diagnosis, typically I would have this diagnosis kind of immediately when I see it, just based on um, common things being common. But we would get a skin biopsy to confirm. And for this particular case, I would actually suggest that we, in addition to checking liver, kidney, blood function, blood counts, I would also check hemoglobin A1C because this condition is called necrobiosis lipoitica. The This condition is also known as necrobiosis lipoitica diabeticor. And the reason being is because although less than 1/2 of 1% of people with diabetes have this necrobiosis lipoitica, usually up to 60% of patients with necrobiosis have also diabetes or pre-diabetes or will develop diabetes down the road. So this patient who has this rash on his, I mean, this is actually a real patient of mine. This patient had an A1C that was in the pre-diabetic range and had not been seeing a primary care, had not been managing signs and symptoms of prediabetes, and had no idea that his blood sugar was borderline for diabetes. This is one of the great situations in dermatology where the skin can oftentimes give us a glimpse of what's going on internally, and we can try to catch things internally before they progress. Sometimes this condition can happen well before diabetes shows up in the blood count. So if we see this as a dermatologist, we know to screen and to get the patient seen with internal medicine, family medicine, someone who's going to help manage this chronic condition as they go forward. All right, one last case, and this is a quick one. So 31-year-old female presents with these well-demarcated, tense, and also somewhat flaccid bulla or fluid-filled blisters and small fluid-filled blisters or vesicles on the ventral forearms. So this is a couple of thoughts when I see this. One of the things that stands out is very demarcated. If you look at both of the forearms, which is what we're looking at, the rash kind of starts and stops at the same place on both arms, which kind of to me tells me that this is something external. Typically, if it was something from the inside out, it would be everywhere, but it also wouldn't be as geometric. So some people are really throwing some good options out. Acid burn, that's great. You know, if you spilled acid on your arms, typically it would be on the same areas, same depth, and kind of show this reaction where it looks like there's a bunch of inflammation or fluid on the skin. So what kind of questions would you ask? Obviously, yes, look at the legs too, always. Unfortunately, this patient just has a rash on the forearms. So what other questions would you ask? Where does she work? Perfect. Chemical exposures at work, environmental or occupational exposures are really good information. It's really good information to get when you're trying to figure out why this is happening to somebody. Great suggestion. Allergic reaction, food allergy. So this is acute. This happened over the last 2 to 3 days. And no history. She works from home. She's home throughout the day. She might garden occasionally, but she doesn't have any recent exposure to chemicals or to acids or anything caustic. These are some really good questions. As someone said, did you come into something, some chemical? That's a really good question. So let's ask more questions. Medications are a good one. This patient doesn't have any past medical history, generally healthy, not on any medications. However, um, given the fact that this rash is well demarcated, you want to think about things that cause demarcation on the skin. So oftentimes it's clothing. So think about when you have a sunburn, which none of you should ever have a sunburn because everybody's doing good sun protection. But if you do, usually the skin that's exposed to the sun will show changes, whereas skin that is covered by something like clothing will show either less changes or no changes at all. So if this patient had on a 3/4 length shirt and was on a medication that could make them more sensitive to the sun, this could possibly be a really bad sunburn or sun reaction induced by medications. So asking medication history is important. I think we have a couple people that just got the diagnosis. So I kind of gave you threw you a bone here and said that she works from home or she's at home mostly, but she gardens occasionally. And given the fact that she may have been in the garden wearing a 3/4 length shirt and maybe some gloves, she may have come in contact with something that irritated her skin. And that is exactly what happened. This is a very whopping, severe contact dermatitis. So this patient specifically presented several days after gardening and came in contact with, she wasn't quite sure what it was, but she had on a shirt that was covering kind of this part of her arm down to her elbow and had on gloves. And her wrist and forearms were exposed. And she got into something that's called this bullous contact dermatitis. The most classic plant contact dermatitis is like poison ivy, which can cause this kind of severe reaction in the skin. We're not sure what she came in contact with, but as you can see, she had a very severe reaction to her to the contact allergen. I meant to put the acid poster, but for this patient, we treated with topical ultra potent steroids for 3 weeks under occlusion. So when we apply topical steroids and then occlude them, or usually with like a saran wrap or tape or some type of cloth, we can allow that steroid to penetrate the skin more deeply and more effectively and clear up rashes a little bit more quickly without the risk of severe systemic exposure from oral steroids. Typically, for this degree of contact dermatitis, which is the diagnosis, we would do an oral steroid to calm it. Given her rash was localized and she was somewhat averse to doing systemic medicine, we tried the topical steroids under occlusion for 3 weeks, and she cleared up. This type of rash can go away on its own over time. However, the degree of itching and swelling that happens tends to leave blemishes and sometimes scars. So you want to treat the skin very quickly if possible. I apologize. I meant to put her after photos in, but she cleared up within 3 weeks. She had some, you can see her arms on her follow-up. Her skin was normal. However, it had a little bit of discoloration in the area, which resolved weeks after. So that's my last case. Hopefully you guys got to see a lot. One of the things I wanted to show you in dermatology is that there are so many avenues you can take. As I mentioned, I'm kind of a general or broad dermatologist, so I am able to see and will see the wide range of dermatology, whether it's pediatrics, whether it's geriatrics, whether it's everything in between, whether it's surgery, or acne, warts, kind of your common dermatologic conditions. As a dermatologist, you get to see and do it all. There are different subspecialties within dermatology that allows you to narrow the focus, but even as a subspecialist, having the basic training as a dermatologist, you can still see all these things and they all correlate. Another thing that I wanted to, two other things I wanted to address is in dermatology, although there is an aesthetic or cosmetic aspect of it, you know, at the end of the day, as a medical doctor, it's our responsibility to treat the patient first, whether they have underlying conditions, making sure you address those underlying conditions in addition to your cosmetic management. And also just being a part of the team. Dermatologists, as you saw in a few of these cases, we can unlock and uncover some underlying medical conditions that patients have. And so making sure you're doing your due diligence to uncover underlying thyroid disease or liver disease or diabetes, and getting patients to see their physicians earlier, it's just helpful in a healthcare team. So my advice when choosing a medical specialty, just explore all the depths from one subspecialty to the extreme subspecialty, so you can kind of get an idea of what your day-to-day looks like. Because whether you're in pre-med, medical school, shadowing, residency, you really only see a glimpse of what a lifetime of practicing a specialty will look like. So, seek it and try to see everything as possible to help you make an informed decision. Thank you guys for having me and allowing me to do this. This is fun. It's kind of allowed me to show you what being a dermatologist is about, and show you some of my fun cases. So thank you again for having me. I appreciate you.
Thank you so much, Dr. Bosley. This was an awesome session and it was super interactive. We all loved it. Everyone make sure you check him out on his socials. His Instagram is Dr. Ron Bosley. All one word.
Thank you.
Yeah. Additionally, thank you all for attending. The link to the Google form has now been posted in the comments, as well as our Instagram bio. So please fill it out within the next 30 minutes for us to receive your verification. We hope to see you all at our next session next week. Again, thank you so much, Dr. Bosley.
You're welcome. Thank you for having me.
We truly appreciate it. Thank you so much.
My pleasure.